Hello, everyone, and welcome to Research Ride, a journey from idea to implementation of research programs in the Department of Medicine at Emory University. I am your ride leader, Charlie Searles, and a faculty member in the Division of Cardiology and the Associate Vice Chair for Research in the Department of Medicine. Hey, Sarah.
Hi, Charlie.
How's your week going?
My week's been busy, but very exciting. We are gearing up for the Department of Medicine Research Day.
Oh, goody.
Oh, goody, and right. Lots of planning going on behind the scenes, but it should be another excellent in-person event.
And who's coming?
Our keynote this year is going to be Ravi Thadani. And
nice.
Yeah, looking forward to hearing him talk. And we're still working on finalizing the rest of the agenda, getting our featured research speakers, which are usually junior, senior researchers in the Department of Medicine. And then also, we're in the process of collecting abstract submissions from everybody in the Department of Medicine, trainees, students, faculty, staff.
It'd be a great networking opportunity.
Wonderful networking opportunity. Everyone is encouraged to attend.
That's fantastic. Are you excited for our guest today?
I am super excited. I've met Dr. Park several times, and she is absolutely delightful.
Yeah, she is a very exciting and innovative investigator, and she studies the flight or fight response. Do you know what that is?
Is that going to tell me whether or not I'm going to run away or if I'm going to stand my ground?
Yeah, she's interested in autonomic function and in particular sympathetic nerve activity and its relationship with chronic kidney disease, post-traumatic stress disorder, hypertension.
Wow.
So it's going to be a very interesting discussion.
I can't wait.
Well, let's get going, okay?
Let's go.
Today, we are very excited to be touring with Dr. Jeanie Park, who is a physician scientist and associate professor of medicine in the Division of Renal Medicine. Dr. Park is also the Deputy Associate Chief of Staff for Research at the Atlanta VA. And Dr. Park's research has been supported and is supported by grants from the NIH, the Department of Veterans Affairs, Department of Defense, and Foundation Awards. I should also mention that Dr. Park is a nephrologist, is a practicing nephrologist, and is an American Society of Hypertension clinical specialist in hypertension. Welcome, Jeanie.
Thank you, Charlie. It's great to be here.
We're so excited to have you, and I was hoping you could start us off by telling us a little bit about your research.
Sure. So I am a nephrologist, as you said, and my clinical and research interest has primarily been in the area of hypertension. So this is really relevant for kidney disease because these are patients that have high blood pressure that's often really difficult to control. So I became interested in this area because I did my fellowship in LA at the University of Southern California. And my mentor there, Vito Campisi, had done a lot of work in animal models investigating the role of the sympathetic nervous system. And so this is the arm of the autonomic nervous system that is responsible for the fight or flight response. So he did a lot of work in animal models that showed that that there was a dysregulation of this fight or flight response or the sympathetic nervous system in animal models of kidney disease and in resistant hypertension models as well. And so I had the opportunity then to translate his work in animal models to humans. And so I was able to go to the University of California in Los Angeles, so UCLA, where I worked with my mentor there, Holly Middlecoff, who's a cardiologist and an autonomic specialist. She was actually an electrophysiologist who was studying sudden cardiac death and heart failure and was able to learn different translational techniques to study the autonomic nervous system, the sympathetic nervous system in humans. And so by learning those techniques that she was using in cardiology patients, I was able to take that back to USC and start studying patients with kidney disease and resistant hypertension and translating some of the work that my mentor did. And so that I started when I was a postdoc nephrology fellow, and I've continued that same line of research over the years. So I was funded with an F-32 postdoctoral award as a fellow. And then I came to Emory for my first faculty position right after I finished my fellowship. And then I got a K-23 grant carrying on that work on sympathetic regulation in kidney disease. And then since then, I've expanded a bit to look at autonomic regulation in other patient populations as well. So as a VA physician, I was taking care of a lot of patients that also have post-traumatic stress disorder. And so people see that on my CV and they say, you're a nephrologist. How come you're studying post-traumatic stress disorder? Well, it turns out that, first of all, this was really something that I needed to know more about because about a third of my patients that I was taking care of with kidney disease also had post-traumatic stress disorder or other kinds of psychiatric illnesses that were linked to their military service. So what I didn't realize, though, was that there's also physiologic consequences of having post-traumatic stress disorder that can also contribute to increased blood pressure and cardiovascular risk. And so I became interested in looking at autonomic regulation in that patient population as well. And so now I have a program really that I would say is focused on the regulation of the sympathetic nervous system, how it is maladaptive in these patient populations. And also we do some clinical intervention studies as well, in addition to these mechanistic studies, to see if there are ways that we can intervene on autonomic dysfunction and improve clinical outcomes.
So that's very interesting because you started with animal models as a research fellow, and you took it to human studies.
I really liked the basic science mechanistic aspects, but then I felt like I was really trained to see patients. So it turns out that there's this area called translational or integrative physiology, which is really a mix of the two. So I'm doing a lot of mechanistic studies in humans. So, we're doing laboratory-based studies. And so it really feels like what I was trained to do as a physician, but also being able to do basic mechanistic studies. So in terms of the transition, I guess, from basic to clinical, it felt very natural to me because, again, I had a lot of kind of basic science experiments, laboratory experience when I was younger. And then I went to medical school and got trained to see patients and make clinical assessments. And so at least the area that I'm in, which is sort of this translational research area, or what the NIH actually calls BESH, which is Basic Experimental Studies in Humans. So it's kind of like basic science in humans. So it actually really feels like what I was trained to do.
You've always been a researcher, but you were a nephrologist before you did this kind of work or got interested in sympathetic activation or in the autonomic nervous system. And I guess that points to the importance of your mentor in that influence of focusing on the autonomic nervous system in chronic kidney disease.
Yeah, that's a really good question because it's funny how you end up doing what you're doing. I do think that people have a calling or a pathway in life. But at the same time, I also feel like I could have been happy studying several different kinds of diseases too. So the story is that I was actually very left-brained growing up, much to the chagrin of my Asian parents. I was not that into math and science. I really loved music and reading and writing. I wanted to be a pianist. I wanted to be a writer. And my first-generation immigrant parents are like, "What are you talking about? You need to go have a practical job. You can go to medical school, you can go to law school, or you can go be an engineer. Those are about your three choices." And my dad was a engineering professor at Alabama. And so first generation immigrants, they have this kid that is wanting to be an artist or a pianist, and it's not jiving with them. And so I actually, at the time, of course, I'm dealing with, of course, wanting to do something that I feel is going to be fulfilling with my life. At the same time, also trying to honor what my parents, their immigrant experience and kind of what their expectations were for us was when I did start doing some research actually in high school and in college, where I could see that, okay, this is science, but it really does take creativity. It takes, it uses those parts of my brain, parts of my skill set that I feel like I was actually naturally good at, actually better at than doing organic chemistry, for example. And so I thought, okay, well, I really want to do, I want to do research. I can do clinical research, go to medical school, and I think I'll probably become a psychiatrist because I really like thinking about the brain and things. And so then I went to medical school at UAB thinking that I might do psychiatry, do psychiatric research. And then, Charlie, as you point out, it's your mentors, it's kind of your experiences that then guide your pathway. So when I did my psychiatry rotation, I realized, okay, this is not exactly what I wanted to do. The clinical aspect of it was not exactly what I thought it would be. But again, that's that specific rotation that I did, and that particular experience that made me think, okay, well, this is not what I want to do. And surprisingly, I was doing physiology, nephrology during the physiology course. And nephrology, I feel like, is one of those kind of, you either love it or you hate it. So I was one of the few strange ones that loved it. And my husband, so I met my husband in medical school, he was one of the more normal ones who hated it. But I loved it and loved renal physiology, loved acid-base electrolytes. Then I actually did my rotation in nephrology. The fourth year sub-I did my nephrology rotation, did ICU nephrology, loved it clinically too. So that's how I decided I was going to be a nephrologist. So I went from, wanting to be a pianist, writer, poet, to psychiatrist, to nephrologist. And so then how did I get to hypertension? So then I went to my fellowship in LA at the University of Southern California. And this was actually a big turning point because I had been at UAB and then I had been at WashU. And LA was just a very different scene for me. It was not necessarily the program that I would have wanted to go to. So I said, okay, fine, I will go to LA. And I went to LA to USC, which is a very strong clinical program. We trained at LA County, lots of patients, lots of pathology, but not a lot of research going on in the nephrology division. But what was going on was research on sympathetic activity. So I thought, well, it's kind of like when you're in Rome, do as the Romans do. I knew I wanted to do research, and it's not like I hated hypertension. And actually, the more I learned about it, the more fascinating it was. And actually, I really like a lot of components of cardiology too, Charlie. So I noticed. Sort of, like being in the CCU and giving hydrolysis. Before everyone would get a PA catheter in the CCU. Do you remember that? Yeah. And so all night long you would give a little Lasix or give a little hydralazine, give a little nitroprusside, and then you could see the PA catheter numbers changing and things. I know people don't really do that anymore, but I love that component to it. So I ended up kind of going into this field because that's what opportunities were available to me there at USC. And my mentor, Vito Campisi, gave me the opportunity to go to LA and learn these translational techniques, where you can measure sympathetic activity in real time in humans. So you can do really rigorous direct measurements, gold standard measures in humans. And so that was what was available. And I ended up really becoming interested in this area. Also realized that none of this work had been done in renal patients thus far. So there was a lot more that we knew about heart failure, that we knew about coronary disease, but had not really been studied in kidney disease. So it was a really it was a great opportunity and a great niche to be in, and sort of low-hanging fruit in a way as well.
Yeah, so any experiment that you do or study you do is publishable because there's no other studies like this.
Right. Yeah, I mean, I'm kind of the lone nephrologist in this field, and I'm also there aren't that many people using these techniques in anxiety or stress disorders either. So people suspect that there is a link between chronic stress and heart disease, chronic stress and hypertension, but nobody had really, or actually epidemiologic studies have shown this link, but nobody had really done rigorous mechanistic studies to try to figure out why. So there was an assumption that there's overactivation of the sympathetic nervous system, but it was based on really crude measures in this patient population, like just blood pressure and heart rate, or heart rate variability. So just indirect measures. And so no one had really taken these tools where you can really interrogate mechanisms in humans and applied it to this patient population. So I'm also I'm the only MD doing that in that area. So yeah, I mean, it's great. It can be challenging because I'm not a psychologist, so I have to collaborate with others for that, to get expertise on that aspect of the research design. But it's great to be able to take these tools into really understudied patient populations.
That is fortunate that you were fortunate that you had that experience and you ended up doing that kind of work and joining us here, I guess, after your fellowship. I was hoping that you could tell us a little bit about how you're making that connection, though, between sympathetic activity or overactivity or dysregulation and these various disease states. So what kind of experiments are you doing to make that connection?
Yeah, so I can tell you a little bit about some of the tools that we use in our laboratory. As I mentioned, when I was in LA, I was commuting to UCLA, which, by the way, I had to be very serious about doing research because I was commuting from the Torrance area all the way up to UCLA. So sometimes that would take me 2 hours to do that. So I was going there to learn a technique called microneurography. So in microneurography, this is really considered the gold standard method to measure sympathetic nerve traffic in humans, and it involves placing a microelectrode inside one of the large peripheral nerves in the body. So in our laboratory, we use the peroneal nerve, which is a large nerve in the lower leg that kind of runs underneath the fibular head. And we place the electrode there, and we can measure efferent sympathetic nerve traffic in real time. And so this is a really powerful tool because not only can you measure sympathetic nerve activity directly at rest, but you can also measure it during different physiologic perturbations. So during sympathetic excitation due to stress, for example, you can also measure how the sympathetic nervous system is being regulated during exercise or other maneuvers. And so we do these direct measures of sympathetic activity, and we also can measure how well or not well the sympathetic nervous system is being regulated. So, for example, the moment-to-moment control of your blood pressure by the autonomic nervous system is largely regulated by the arterial baroreflex, and we can test that in the laboratory. And we do this in the hospital setting by manipulating arterial blood pressure by giving nitroprusside and phenylephrine, and then we can measure the response of the sympathetic nervous system in response to changes in blood pressure. We also have a lower body negative pressure chamber, which is like this big metal garbage can that we can change venous return to the heart. So we can manipulate blood volume, and we can look at hemodynamic changes that way. So we do experiments in our participants by which we can interrogate sympathetic nerve activity at rest, as well as reactivity, as well as how it's being regulated. And so then with that knowledge, we can then look at outcomes, for example. So we can do longitudinal studies and see if any of these can serve as a biomarker for poor outcomes. We can also look to see if there are interventions that can improve autonomic regulation or decrease sympathetic nerve activity in these patient populations. And then also look to see if that then translates into clinically meaningful changes, for example, in blood pressure or even in cardiovascular outcomes. And so yeah, we have this mechanistic component where we bring participants in to really try to understand mechanisms. And then we also can do these clinical trials where we are looking at different strategies and approaches to improving autonomic function in patients.
So just to be clear, the autonomic nervous system is, everyone has an autonomic nervous system, and that this is actually a evolutionarily conserved response to external and internal stimuli.
Right.
And normally it's beneficial to have these responses, that your heart rate and blood pressure go up when you need it, and your heart rate and blood pressure go down when you don't need it.
Right.
And so you take your participants and you put a needle in their leg, and then you give them some kind of sympathetic stimulus, I guess pressure to return blood to the heart, and you stimulate these baroreceptors. Can you just tell us what the baroreceptors are and where are they?
Yeah, sure. So we have two kind of major baroreflex systems. One is the arterial baroreflex, which we call high pressure baroreflex system. And so these are afferent nerve endings that are located in the carotid sinus and the aortic arch. And so when your blood pressure goes up, then there's these afferent nerve endings become engaged, and that leads to a reflex decrease in sympathetic activity. And then conversely, if blood pressure falls, then the afferent nerve endings within the vascular walls then become unloaded, and then there's a reflex increase in sympathetic activity. And so this is all in an attempt to keep blood pressure within a narrow range. And so that's the arterial baroreflex. The cardiopulmonary baroreflex is considered more the low pressure or volume sensitive baroreflex. And so this is the one that's really triggered when you stand up, for example, and your blood falls to your lower extremity so that you don't pass out. So these are baroreflex nerve endings are located in the lungs and the cardiac atria. And so when there's decreased venous return to the heart or less pressure going to the lungs, then that leads to a reflex increase in sympathetic activity, and so that's actually independent of the blood pressure. So you have these two systems. One is sensitive to blood volume. The other one is sensitive to blood pressure, and we can test the integrity of these systems experimentally in humans. So for the arterial baroreflex, I think, as I mentioned before, we can give intravenous boluses of nitroprusside and phenylephrine. And so what we're doing is we're activating the baroreceptors, and then we're unloading the baroreceptors by giving these drugs. And then we can look to see, well, is the sympathetic nervous system doing what it should be doing? Is it going up when we give the nitroprusside? Is it going down when we give the phenylephrine? And then we can also look at vagal activity to the heart too. So is the RR interval going up as it should? Is it going down as it should? And then in terms of the volume, the cardiopulmonary baroreflex, this is one of my favorite things to do, is you put them into this lower body negative pressure chamber. It's they have really fancy ones that cost $50,000 that do tilt, and they're super fancy. So ours I actually inherited from my mentor at UCLA. She shipped it to me from LA to Atlanta, and it's literally like a giant metal garbage can. And it has a little lid, so the participant goes inside of it. Then we take a so with the garbage theme here, you take a garbage bag and you basically tape the end of the canister to their T-shirt or to their shirt. And then we do microneurography through the little hole, and then we shut the chamber. And then we literally put
So their leg is up against the hole in the chamber, you're saying? So
the leg, so we open the chamber, we do the microneurography, and then we close the chamber so that they're inside the chamber with the electrode in.
I see.
And then we take it's literally a vacuum cleaner, like a handheld vacuum cleaner, and we hook it up to the lower body negative pressure chamber, and we turn on the vacuum cleaner, and we can control the power of the suction on this regular vacuum. This is like a $25 vacuum cleaner. And so the higher the suction, then the more lower body negative pressure. So we can measure the amount of lower body negative pressure just using like a gauge that we got off Amazon. And so you can see how much lower body negative pressure you're applying, and then you can actually have like this dose response. So a little bit of lower body negative pressure, how much is your sympathetic activity going up, how much is your heart rate going up, and you can actually measure the sensitivity of these volume receptors to lower body negative pressure. So at the time when I came, I didn't have enough money to get a real lower body negative pressure chamber, so I got that. And over the years, I have plenty of funding now, but we've never changed, and it works quite well, actually.
So this is on the second floor of Woodruff?
Yeah. Yes, it
That's
is.
in 2109 or something?
Yes, and you're welcome to get in at any time you would like, Charlie.
Haven't actually been in that room, but sounds like... Take me to the garbage chamber. So what have you found with these experiments as far as the responses of your different groups of participants?
Yeah. So
I understand you have a lot of exciting results, and I think our listeners would like to hear like some of the findings here.
So I can give you a few kind of more long-standing studies that we've done in the lab. So I mentioned that I learned this technique from Holly Middlecoff at UCLA. She was my mentor, my scientific mentor, continues to be my scientific mentor. So she was looking at the regulation of the sympathetic nervous system during physical activity in heart failure. And so at the time I thought, okay, well, I'm just going to do the same thing in chronic kidney disease. So I did that, and lo and behold, it's quite interesting. So patients with kidney disease, so this is I should say that people that have kidney disease, they don't tend to die from renal failure. In fact, very few of them go on to make it to end-stage kidney disease because they're all dying of cardiovascular disease beforehand. So you're up to 20 times higher risk of having a cardiovascular event. And the physiology and the epidemiology of the cause of your cardiovascular disease is also different in this patient population. So a lot of them have sudden cardiac death, for example. So it turns out that people that have kidney disease have this exaggerated increase in blood pressure during any kind of physical activity. So this is true of light physical activity, or like opening up a jar of peanut butter, for example, or more strenuous physical activity, like going up a couple flights of stairs. So this is obviously not a good thing because this increases risk of cardiovascular events, to have your blood pressure having these exaggerated blood pressure responses during physical activity. And so we look to see, well, what is underlying this exaggerated blood pressure response? So it turns out that there is an exaggerated increase in sympathetic activity that's occurring during different forms of exercise, and it appears to be mediated by an aberrant exercise pressor reflex. So when we exercise, we have an increase in sympathetic activity that's adaptive. So you want that to happen. Why? Because you want to increase your cardiac output so you can meet the metabolic demands of your exercising skeletal muscle, but you also want to be able to vasoconstrict areas that are not working, namely the kidneys, right? So that's a great area to shunt blood, vasoconstrict the kidneys, and then shunt blood to the exercising skeletal muscle. So it's adaptive. But it turns out in kidney disease that there's an exaggerated sympathetic response that is at least in part driving this increase in blood pressure. So why is this happening? Well, this reflex response is actually coming from the muscles itself. So in the muscles, you have these muscle afferent nerves, and they can be activated by different things that happen during exercise. So one thing that happens during exercise is that you've got muscle contraction. And so the muscle contraction will activate these afferent nerves, these mechanical nerve endings, and cause this reflex increase in sympathetic activity. And then you also have these metabolic afferent nerves too, so metabolically sensitive. So when your lactate levels go up or your pH goes down, then that triggers these set of nerves to increase sympathetic activity. So you have both of these going on. And long story short, in chronic kidney disease, it does appear that these mechanically sensitive nerves are responsible for this exaggerated response. So we did discover that in kidney disease. And we've gone on to look at that further to see what it could be in the muscle that is driving this. Is it a specific type of uremic toxin? Is there also an interplay of what's going on with the renal sensory nerves that might also be interacting with what's happening in the muscle to increase sympathetic activity? And then the flip side of that is that it's not just the sympathetic nerve activity, as much as I love to focus on that, but also what's happening on the other side. So we've also looked to see, well, when you have sympathetic nerve activation, you have this release of norepinephrine and other neurotransmitters, and then they bind to vascular alpha adrenergic receptors. And so we look so the going paradigm is that if you have increases of norepinephrine or increased ligand of any kind, then the receptors are usually downregulated. And so that's what was thought to be happening in kidney disease. But it turns out that actually the vascular alpha-1 adrenergic receptors are upregulated in kidney disease. So you have like this double whammy. So not only do you have an increase in sympathetic nerve activity, but you also have this exaggerated vasoconstrictive response when you have sympathetic nerve activation and release of norepinephrine. So we actually have shown that as well. So we've uncovered, I think, some new knowledge about what is causing these exaggerated responses in blood pressure, increases in blood pressure variability during something. So when I say exercise, people are like, well, so exercise is not just running a marathon, but it's also being able to walk to your mailbox and check your mail and things like that too. So this is people just doing their activities of daily living with kidney disease, have this abnormal, exaggerated sympathetic response.
So this is the exercise intolerance. That's the mechanism responsible for the exercise intolerance of these patients.
Yeah, I think it's at least a partial mechanism. Exercise intolerance in kidney disease has actually been studied quite a lot by nephrologists, but more from a vantage point of what's happening to uremic muscle. And acidosis and how's that affecting muscle quality, or from cardiopulmonary type of studies, exercise capacity, but hasn't really been looked at before in terms of what's happening hemodynamically and neurocirculatory control during exercise. And I think it's actually linked to those other mechanisms though. So poor muscle quality, uremic toxins, acidosis affects muscle quality, and then acidosis itself may also be activating these muscle afferent nerves. So that's actually something that we're actively looking at right now with the latest grant in kidney disease.
That is enlightening. So the question though is, chronic, are we in these patients, we're talking about chronic sympathetic activation?
Yes.
And that is a state that is common to different diseases besides chronic kidney disease, right?
Right. Yeah. So yeah, I've kind of told you about sort of the activation of the sympathetic nervous system, but there are definitely patient populations that are characterized by chronically high sympathetic nerve activity that is directly linked to increased risk of cardiovascular disease and cardiovascular events. So patients that have chronic kidney disease at rest, so even without any kind of sympathoexcitatory stimulus, have higher resting sympathetic tone. That's true of heart failure, and it's true of many other diseases as well.
I mean, hypertension itself, right?
Hypertension itself, yes.
And you're seeing similar type responses, or I guess the PTSD, the post-traumatic stress disorder patients, the patients under chronic emotional or mental stress have a similar type response?
Yeah.
Although I guess you might not be exercising those folks, or are you? Is that?
No. So the PTSD story is that I think, as I mentioned, that I was taking care of patients that have comorbid PTSD, but a lot of our CKD patients that were coming into the laboratory, because I was studying primarily veterans, many of them had comorbid PTSD. And what we noticed is that those with comorbid PTSD seem to have even higher resting sympathetic activity. So that's what led me down this pathway. And then looking at the literature, if you have PTSD, it's an independent risk factor for developing hypertension later in life. And so I wanted to see, well, is there something happening before the development of hypertension that might be predisposing these patients to developing an increase in blood pressure? So what we found in that patient population, so we were interested in investigating, well, what is happening at rest and during chronic stress in patients that have post-traumatic stress disorder, but are still normotensive. So when we look at this patient group compared to veterans without PTSD, and we really tried to match the controls for combat exposure, they're all veterans, so we try to control for as many different factors as we could. What we found is that there is actually no difference in the resting sympathetic activity between a young patient without hypertension but with PTSD compared to a control. But when you apply stress, we are seeing exaggerated increases in sympathetic activity during stress.
Mental stress.
During mental stress, that's right. And so the mental stress that we've looked at was, and this may seem obvious, but we did focus on patients that have combat-related PTSD. And so I collaborated with Barbara Rothbaum to do a virtual reality combat exposure. So this would be a stress that is related to their PTSD symptoms. And so when we expose the participants to this virtual reality combat exposure, then what you see is this exaggerated blood pressure and sympathetic response in those with PTSD compared to those without, which you may expect, but actually this virtual reality exposure is really a neutral stimulus. It should be a neutral stimulus. So this may be mimicking what's happening potentially during nightmares or flashbacks, et cetera. So we're seeing that there's this there's this exaggerated sympathetic response. But what was really interesting is that this seems to extend to other types of mental stress as well that doesn't have to do with their PTSD symptoms. So, for example, when we administer mental arithmetic, which is a pretty powerful sympathoexcitatory stimulus, what you'll see is that the PTSD participants have this exaggerated response during math compared to those without PTSD. And so that was interesting to us, but it didn't extend to all stimuli. So when you do the Cole pressor test, there was no difference. So it seems to be that it's mental stress, but it's not just confined to their PTSD symptoms.
So what about the volume baroreceptors in those patients?
Yeah, you really read through my CV. So we have not looked at the cardiopulmonary baroreflex yet in these patients, but we did look at the arterial baroreflex. So we looked to see, are they able to dampen their sympathetic activity when their blood pressure goes up, right? And so we did what we call the modified Oxford technique, which is the gold standard for arterial baroreflex testing. So this is not done in Woodruff. This was done at the VA hospital.
Okay.
And so we put an IV in and we give a bolus of nitroprusside and then we give a bolus of phenylephrine. And that causes about a 40 millimeter mercury fluctuation in blood pressure. And we can look to see is the sympathetic activity going up and down as it should. And so the steeper that relationship, the higher the sensitivity. And then the more blunted it is, the lower the sensitivity. And it turns out, exciting conclusion is that people that have PTSD but not hypertension, they have a blunted arterial baroreflex, meaning that when you give phenylephrine and blood pressure goes up, they are not appropriately dampening sympathetic activity. And we know that independent of blood pressure, if you're not able to regulate your sympathetic activity appropriately through the baroreflex, that's an independent risk factor actually for cardiovascular events. So this may be one mechanism that is leading or contributing to some of this exaggerated blood pressure response during mental stress, but also could explain some of that increased risk for future hypertension.
Long-term outcomes.
That's right. Yeah.
I was trying to work my way around to the mindful breathing because I want to finish with that discussion, but I finished this research discussion with that because I find that fascinating. And in particular, there are, what comes to mind is yoga as a practice of mindful breathing, right? Or one of the arms of yoga is to focus on your breathing, and how your data might support the recommendation that everyone do yoga. Or
Yeah. Well, thanks for bringing that up, Charlie. I really think that we need different modalities for intervening on the sympathetic nervous system. So I'm really we're interested in different modalities, different therapeutic interventions to improve sympathetic activity that doesn't have kind of like this total wipeout effect that giving clonidine or giving beta blockers might have. So we have several lines of different interventions, different modalities that we're interested in. So we're interested in non-pharmacologic approaches. We're doing exercise training, for example. We have neuromodulation types of things that we're looking at, so vagus nerve stimulation. And we are also very interested in both device-guided slow breathing and meditation slow breathing. So there is a physiologic basis. Well, there's a evidence base and also a physiologic base for why we have chosen those particular interventions. So in the case of meditation and slow breathing, there are studies that have shown, not all of them, but plenty of pretty well-designed studies that have shown that slow breathing can reduce blood pressure. And so we took that to look to see, well, what's happening during slow breathing acutely and what's also happening long term. So the physiologic basis is that with slow breathing, you're expanding your chest. So if you breathe slowly, then your tidal volume goes up, right? So you need to maintain your same minute ventilation. So if you breathe 5 breaths per minute instead of 15 breaths per minute, then you compensate by increasing your total tidal volume.
To keep your blood oxygenated.
That's right. Yeah. So you get rid of your CO2 the same way, et cetera. And so when you do that, you're expanding your chest and you're unloading the cardiopulmonary barrier reflex. That's the idea. And that leads to a decrease in sympathetic nerve activity. So what we found is that in the PTSD population, for example, if you do slow breathing, that you can lower sympathetic nerve activity acutely. And what we've also found is that if you do it for 8 weeks, that at the end of the 8 weeks, there's no change in the resting sympathetic activity, but you can ameliorate this exaggerated sympathetic response to stress. So we found that as well. Meditation.
8 weeks. I mean, I'm sorry. You do it 8 weeks. What does that mean? You do it every day for 8 weeks?
That's right.
Okay.
Yeah.
For how long is that?
So for the device-guided slow breathing, they did, I think it was 15 minutes a day, twice a day or something like that. I can't remember exactly the protocol, but yeah. That is actually one of the limitations because it definitely has a more of an effect when it's being done acutely. For sure, you see this reduction in sympathetic activity, but people go back to breathing at, their normal 12, and then that effect seems to go away. But there is some long-lasting effect in terms of the reactivity of the sympathetic nervous system.
Once you stop the training.
Right, yeah.
So have you studied any yogis?
I have not, but we are administering at the MBSR, which is mindfulness-based stress reduction. So that is a mindfulness intervention. That's the one that has been most studied for blood pressure outcomes. So we are doing that with and without vagus nerve stimulation to see what we can do to intervene on sympathetic overactivity. And I feel like this is going to be probably a combination of different things that may intervene to improve sympathetic function. So it might not be, okay, now we're just going to have everyone breathe at 5 breaths per minute every day. It might be kind of doing that plus having some mindfulness, doing neuromodulatory things, exercising, maybe all of the above to try to really have the ideal clinical impact.
So the meditation part is important.
Yes.
Not just the breathing, right?
So we think that there is an important part. We think that the slow breathing down to 5 breaths per minute alone does have a physiologic impact by itself without the mindful component. We do think that there is a central kind of top-down signaling that is happening with mindfulness itself that is modulating the sympathetic nervous system. So we have shown actually during mindful meditation with slow breathing, but not down to 5 breaths per minute, but with some slow breathing that has an effect on blood pressure and sympathetic activity. And these were in older patients with chronic kidney disease.
This work is fascinating, and I think I could continue for another hour. Do you have time? But I don't think our listeners might not have all that time. So I wanted to sort of wind down the research ride, and we have a couple of questions that we ask our guests each time they come into the studio here. And the first question is, what is one thing you did early in your career that you would advise others to do?
What did I do early in my career? I would say to try to be fearless in some ways. Everyone talks about how difficult this career path is. I mean, it certainly is. But if you have this strong desire to do it, then don't give up and do it, and be fearless and do it. It's kind of like an analogy of sort of, when you're in residency and you're an intern and, you're working 100 hours or whatever, Q3, if you had this mindset that, if it gets hard, I'm just going to stop, or, that stopping was not really an option. Like you really wanted to achieve this end goal. So,
keep working for your goals.
Keep working through your goals. Yeah.
Even if there seem to be obstacles.
Yeah.
That's a common theme, I think, amongst our guests, actually. And the flip side of that is, what is one thing you did early in your career that you would advise other young investigators not to do?
Yeah, that's a hard one. I think for me, I really wanted to do it all. So I wanted to be, the number one best nephrologist in the state of Georgia or whatever. And then I wanted to be the best clinician. I wanted to be the best I wanted to know how to treat lupus nephritis just as well as everybody. I just wanted to be an expert at everything. And I think so it was hard to kind of prioritize some things over other things, but I really still love seeing patients, and I may not be the one that everyone comes to get their lupus nephritis treated, but I still have that satisfaction of having this, this really fulfilling career where I can do all different kinds of things, like see patients and do research. But yeah, I guess just trying to protect your time to what you're prioritizing rather than trying to do it all, which is what I did try to do at the beginning. So yeah, sometimes I think you have to just kind of go through that to figure out what it is actually that is your priority and that really is fulfilling for you in your career.
Make a priority list and stay to it or stick to it.
Yeah.
That's very helpful advice. Incredible. Okay, so that takes us to the Research Ride playlist.
You told me you were going to ask me this. I should have prepared better.
And if you could give us 2 or 3 songs that you would like to put on that Research Ride playlist.
Okay, let's see. I'm looking at my phone. So Brown Eyed Girl, Van Morrison.
Nice.
Is that already on there?
Nice.
Okay, let's see. I let's see. So U2 won.
Oh. That's
Want
sticking with the Irish theme there? Is that?
I guess so. My taste is eclectic. You can see.
Sinead O'Connor is the.
That's on there too, yeah. Bob Dylan.
All right, nice.
Yeah.
All right, that's very good. That is quite eclectic.
Yeah.
Any specific Bob Dylan?
Oh,
I could pick a lot.
Tangled Up in Blue. I think it was
Oh,
on
no,
there.
that's a great song. Dr. Park, thank you so much for coming to the studio today and sharing all this great information about your research program. It was really an awesome tour of your research program. Thanks for joining me on another great research ride. Producers of this podcast are Sarah McClellan and Ben Searles. Ben is also the editor of this podcast. Theme music composer is Hannah Searles. This has been your ride leader, Charlie Searles, and I will see you next time.